Before we get into today's episode, I want to share something that I think a lot of you need to hear about. Heart of Medicine 2026 is an international gathering of compassionate leaders in medicine. Doctors, nurses, allied health clinicians, coaches, healthcare leaders, all coming together July 29 through 31 at Voyagers Ayers Rock Resort in Central Australia. And yes, it's in Uluru, the spiritual heart of Australia. Because this event is intentional about where it places you, not just what it teaches you. You'll learn from world-class faculty about heart-centered care, compassionate leadership, and what it actually looks like to build a longer, more fulfilling career in medicine. You'll leave with the skills, community, and honestly, your spirit a little bit more intact. This is not a typical CME box check. This is the kind of gathering that reminds you medicine is still worth fighting for. I'll be there, and I'd love to see you there. Registration is limited because the resort is remote and intimate. So don't sit on this one. Link is in the show notes.
Welcome to Heartline, Change-Making in Healthcare. I'm your host, Dr. Andrea Austin, a board-certified emergency physician, physician development coach, and educator. After years on the front lines, I've learned that real change in healthcare starts within. Each episode invites you to explore the inner work that unlocks clarity and bold leadership, because healing systems through change-making begins with following our heartlines.
I am thrilled today to have Dr. Harry Severance with me. He is a fellow change maker and very passionate about the workforce development and changes that need to happen to make sure we have the clinician workforce to meet the challenges that we're dealing with in emergency medicine and beyond. He is an assistant adjunct professor from Duke and has an extensive clinical experience. And for me, I would characterize him as a partner in crime as we try to really make some big changes. We're currently working on an article about some of our big ideas about how we can transform medical education and make things better for everyone, for our patients and for our colleagues. So with that, Dr. Severance, Harry, I'm just so happy to have you here today.
Glad to be here. Glad to be able to contribute.
So being a change maker is not easy. I was on a call just before this podcast recording. I actually showed up late because I was in the middle of what I feel like is swimming upstream. So this isn't easy work to do. So how did you end up getting involved in trying to make a difference in medicine?
It's a long process. I can't relate a single sentinel experience that I can say, whoa, boy, that turned me around or focused me. I've been in healthcare for decades and worked clinically during that time. Also been involved with education of medical students, residents, and others in healthcare. But over these decades, I've started to see and continue to see a huge change. And part of this may be because decades ago, the medical school I grew up in was very focused on hands-on patient care and lectured to then me as a medical student about don't worry about the finance, don't worry about the economics, don't think about your paychecks. Your job is to take care of the patients. Others do that kind of work. Your goal is to provide healthcare. And that works as far as physician-patient relationship. But over the decades, we've abrogated the management of healthcare to others who don't have our level of concern over patient outcomes. And over the past couple of decades, what we've seen for a variety of huge global and national economic reasons is that healthcare has become big business. And big companies that do big business have increasingly migrated in to healthcare practice and now run and manage healthcare organizations. Their goals are radically different than what a clinician has in providing patient care. And what I've seen over time as big business has taken over more and more hospitals, medical practice has become corporate managed, and the teams, your CEO suite may not even be in your local hospital anymore. It may be across the country. It may be in a different country. But those that now at the senior level manage healthcare have essentially no experience. They've never taken care of a patient and furthermore don't want to. So their goals, again, market share, economics, profit, cut economic losses. These are their mantras. And you hear nothing in there about patient outcomes, patient wellness, patient well-being, doctor-patient relationships. And what I've seen is that the healthcare workplace for more and more of our physicians, nurses, other healthcare hands-on providers have become, some would say, a battleground of trying to fight for your patients while getting slammed by everybody, including your employers. So what I've seen in my counseling and advising, that has grown over time. And what I'm seeing more and more of is physicians, nurses, nurse practitioners, physicians assistants, and all along the line of those who have hands-on patients becoming more and more burned out, dissatisfied, unhappy, feeling maligned and pushed aside by those who now manage them. And more are leaving clinical healthcare practice. You ask, what can we do to make healthcare better? The first thing we would have to do is look at well-being in our healthcare workplaces for physicians, other healthcare workers, our patients, the number one priority, and put that as a number one goal rather than market share, profit margin, stuff like that. Healthcare is a business. We have to accept that. But I believe there are better ways that it could be run. One scary statistic that I just saw recently in 2025, for the first time ever, we have more physicians that have left the United States than physicians that have entered the United States to seek medical practice. That's a scary statistic. And when you see the numbers of physicians, nurses, and others who are continuously leaving the healthcare workplace, there is no way that all the education programs currently available in this country can keep up with those losses. So we see in the state where I clinically practice, Tennessee, the Hospital Association just announced their data shows that the state of Tennessee, that has 5 medical schools, will have a shortage of up to 4,000 or more physicians by 2035. So there's no way that our current system can keep up with the losses. Yet at the same time, we see, and I see, because I have it frequently, physicians, nurses, others in healthcare. Now I'm actually getting calls from some medical students that say, can you guide me to get out? Is there a way I can leave medical school and find another career? I the same thing, saying our brightest young minds are turning away from healthcare because, again, of what they see in the workplaces and saying there's a happier career for me. So again, I can go on for a long time, but my point is, until we change the quality of our healthcare workplaces as directed by those who manage, we're going to see continued attrition at all levels and in all clinician types. And it's going to end up badly for patients.
Yeah. A question that comes to mind is, I think most people would say we've got to make a change. I really do feel that we're getting to a point where you feel patience, you feel the people working in it. And, I was actually at the Florida State House a couple months ago, and politicians on both sides of the aisle said that they were fed up and that things needed to change. And it was actually interesting that I actually couldn't tell if I was speaking to a Republican or Democrat when it came to talking about the problems in the system. They were pretty uniform in being able to describe the issues. My question for you is, do you think that there can be a place for profit healthcare, or are you of the mindset that we need to move to single payer? If you got to be in charge of this United States healthcare overhaul with all that you've seen and learned over your career, what is your prescription or fix?
There's not a simple black or white answer for that, in my opinion. Single payer is the practice norm in many countries, many technologically advanced countries that have excellent healthcare systems. Right now, again, data statistics, we currently have the most expensive healthcare system in the whole world, far beyond other comparable systems such as Germany, in some ways the UK, but Germany, certainly Switzerland. But our outcomes are worse in so many areas. So again, sooner or later, that's non-sustainable. But when you look closely at other comparable systems, the German system is a good one to look at, not the only one. But yes, every citizen of that nation has the option for nationalized, which you would call single payer, the government sponsored healthcare. But all these countries also have a pathway for private, profit, gendered healthcare that is available. And so again, I say the answer is not simple. But the one thing I think this country needs is, and I wrote a paper on this recently, is that we do need some type of baseline healthcare for all American citizens. And there are reasons beyond patient outcomes. The stability of the country, I believe, rests on that. You mentioned talking to legislators, and I feel this is something they really need to focus on. Right now in this country, as of 2024, over 35% of American citizens can no longer afford healthcare, cannot access it, or get sick. They show up in emergency departments, in hospitals, increasingly ill because they have no ongoing care. As an emergency physician, you probably see this every time you work.
Every day.
And they need now rather than something simple, they need admission to the ICU. They need weeks hospital for stabilization, rehab, and they have $1 million bills, which they cannot pay. The biggest single reason in this country, in the United States, for personal bankruptcy filings is unpayable medical bills. Over 60, and this is going up closer to 70% of all personal bankruptcy filings are for unpayable medical bills. And that's going to accelerate. The numbers get worse. I said 35%. Realize that's 15 points south of half of the entire population of this country. They estimate that with the cutbacks from the new current legislation, I think some people call it the big, beautiful bill. But anyway, the cutbacks in Medicaid, Medicare, Affordable Care Act, they estimate that the people who cannot afford ongoing healthcare will go up above 40%. Some people say maybe 50. But my point is, when you get up to almost half of the population of your country who cannot afford or access ongoing or stabilizing healthcare, it not only is a crisis for the people who get sicker and sicker and less able to afford, it's an economic instability crisis for the country. What country can survive when half their population can't perform at work or contributing because they're too sick and can't access healthcare? It becomes a political and economic challenge for such a country. What's my point is I believe that there needs to be in this country some pathway for, if you're an American citizen or other legal resident, there needs to be some baseline healthcare that you can get for reasonable rates or provided by the government. And so what I'm suggesting is an anathema to many in this country, but I'm talking about a multi-tiered system where there may be a back of the bus, middle of the bus, front of the bus. But in every other aspect of our workplace, we see that all the time. So why do we find that so abhorrent when we talk about healthcare? Other countries do it with highly successful medical practices. So I think that's something we really need to look at. If we don't, here's the problem. If we don't, and I wrote another article that I just published recently, the statistics are now unsupportable financially. We're headed to a huge economic crisis in healthcare. When you have, as I mentioned, 40% of your entire population can't afford healthcare, the biggest single reason for bankruptcy filings is unpayable medical bills. And I saw this recently, just last year, 2025. As a nationwide, the average collections from hospitals on services they rendered was less than 50%, 47.8 nationwide on an average. What business can stay open when over half of your clientele don't pay their bills, but the laws say you have to provide the service anyway, which hospitals are required to do? You either provide the service, sooner or later, your bankruptcy and your hospital closes. We've seen 800 hospitals in this country are failed financial stress tests last year and at risk of closing, and that is expanding daily. So my point is, if we don't do something to fix this healthcare crisis of lack of access of half of the population of this country, it will crash the healthcare system. It'll crash us politically and crash us socially. The results of that type of crash are not going to be pretty to behold.
As an emergency physician, I've seen firsthand what happens when people lose themselves in their work. That's why I built a coaching practice grounded in real data, not guesswork. When we work together, you'll start with a DISC assessment, which will generate a 40-page deep dive into your behavioral strengths, your motivators, and the workplace triggers that cost you the most. Then we bring in objective biometric data. We can use any number of wearable devices, including the Oura Ring, to understand how your sleep and recovery directly shape your capacity for joy and performance. This isn't a one-size-fits-all program. Every coaching engagement is customized to you because the work of following your heartline looks different for everyone. If you're a healthcare professional ready to reconnect with why you started, visit the link in the show notes or head over to AndreaAustinMD.com. So I think most of the listeners of this podcast may not be able to quote all those statistics, but they're fully aware. They feel it. They feel it when they go in to work. And so for the emergency physician, the hospitalist, the physician associate, the clinicians listening, what can they do? Because we tend to be action-oriented people. What would you suggest?
Well, there's several you can approach: top down, bottom up. Top down would be physicians, where possible, should try to, and this is difficult these days, to re-engage in management of hospitals and healthcare systems. Wherever we can, we should seek a seat at the table of senior management. I've said that's not easy because these huge business systems that now run healthcare often do not want the input of clinicians. They do not want physicians seated at the table. So it's difficult to gain access to these senior C-suite management systems, but wherever we can, we should strive to do so. That's top down. But healthcare as a business system has to change in order for healthcare to survive and do well without a crash. From the bottom up, it's not a pathway I necessarily find myself eager to endorse, but what we're seeing nationwide is a move of physicians, nurses, residents, medical students to unionize. And we're seeing more, it's a groundswell. 10 years ago, I believe if I'd lined up a group of physicians and say, want to join a union, they'd all start throwing tomatoes at me. Today, we have their whole conferences at national assemblies, such as American College of Emergency Physicians. There are huge presentations on unionization, the good and the ill. But we're seeing this is a way to bring management to the table. It's the bargaining table. But if you threaten to shut down your hospital unless things change in the clinical workplace, you suddenly get attention. Like I said, we need to focus again. I mentioned when I first started talking how clinicians have abrogated the management of healthcare to those with MBAs and other similar. We need to get back into the taking over the management of our systems in order to improve our clinical workplace and our patient outcomes.
Do you see a big part of the barrier to physicians being involved in that clinical management being the Stark Law. And for listeners that maybe aren't familiar with that, there was a law passed and essentially, maybe was done with some intentions of trying to protect patients. But what they essentially said is that physicians can't own hospitals. And a lot of people point to the Stark Law as one of the death nails to our system. Certainly the emergence of HMOs. But what's your opinion on the Stark Law? And is that something that we should be advocating for reversal on?
Yeah, you bring up a great point. The Stark Law and similar acts. If you and I have, and I have talked to some senior corporate business healthcare leaders, no experience and never seen a patient, don't want to. And what they tell me off the record, and I've gotten this from more than one huge healthcare system, is I mentioned earlier, they don't want physicians seated at their senior management tables. If you look again at the data, you'll find when you look at, there are some articles about the top 20 hospitals in the country and the top 20 systems. If you look, there are only 11% of all members seated on all these major decision-making boards that have an MD degree. Gets worse for nurses. It's like 0.4%. But if you dig deeper, you'll find that none of those are clinically practicing or have any connections with any clinician-based practice. They're totally divorced from that. And that's by design. Again, off the record is what these business leaders tell me is they're terrified about the Stark Law. Okay. Now, what's that got? The Stark Law says more than just physician owning a business. It talks about referrals. You preferably refer your patient to an organization in your business structure when clinically the patient would have done better going across town to another group. Okay. And this was the design of the Stark Law to guarantee good patient outcomes instead of just business stirring the pot. It's had the exact opposite effect because now corporate leaders tell me they fear putting clinically practicing physicians, nurses, or others on their decision-making boards for this reason. Now we see corporate healthcare is vertically and horizontally challenged, moving all up and down. So healthcare systems, they own every segment of healthcare. Okay. Now they refer within those organizations all the time and they defend their actions saying good business practice. I mean, if you think about it, what other industry would require you to sunset out part of your business operations? Would any politician in their right mind tell General Motors, we're passing a law that says you have to buy all your brakes from Ford? Huh? You see what I'm saying? Right. Where in general business, do you keep it all in-house, especially if you own multiple houses? So there are decisions that have to do with how patients are transferred from organization to organization, all of which they own. If there are no physicians or others with clinical licenses sitting on those boards, making those decisions, then their legal people tell them you are much less likely to run afoul of federal investigators trying to tag you to Stark laws or other similar actions. And they further tell me, yes, the feds can do anything or bring any action, but they, like anybody else, look for, do we have a high likelihood of winning this case? And when you have boards making business-like decisions where nobody is a physician, nobody has any direct clinical contact with the organizations that they own, it's much more likely that a jury or a set of judges would say, good business decision. What do you have wrong with that? So that's one major reason we see corporate healthcare discouraging physicians and others who are practicing clinically from sitting on these major boards. Yet those boards are the ones that make the decisions that directly and many affect your clinical workplace in my clinical workplace on a day-to-day basis.
So coming back to this idea of one suggestion was getting a seat at the table, being involved in your healthcare system to the best of your ability. What other helpable actions can people take? Because I think one of the most concerning trends that I see, and I fell victim to this for a while, is there's a great amount of apathy. When I talk about these issues with my colleagues, at least half of them say, the system's too big, it's too complicated, I'm just one person, I can't do anything. How do we get more of our colleagues to wake up and exert more agency and ownership in the process?
You ask a difficult question. If there was an easy answer, I think many would already be doing it. But I think as an individual, you feel yourself, again, overwhelmed. And in my advising role, I see this every day. Physicians, nurses, others who have basically given up, and they go to work with their head down and just, can I make it through another day? Or I had one physician recently that told me and went to great lengths on how he hated his job, but had no way out. He said, my family lives here. They're the hospital. I have a clause in there that says I would have to leave the city or the state in order to continue to practice medicine. So my family's embedded, their family, I just put my head. But he said, I'm buying this new car. And I forgot, was it a Porsche something? This fantastic new car. And he said, it gets delivered in a couple of weeks and I'll at least enjoy driving to and from work. And that popped in my mind. There's a song, I think it's by Billy Joel. And he talks about something about you can't drive your car with a broken back, but at least you can polish the fenders. And and I thought about, here is this guy who is trying to find some joy in buying some fancy car to drive to the job that he totally hates. But my point is, how good a job can you do? How well can you provide patient care when you hate what you're doing? There's no easy answer for your question, but can local, regional, state, national organizations, your state medical society, your state for emergency physicians, your state chapter of the American College of Emergency Physicians, going to Congress, which I'd like to do, but getting it more and more involved politically, that's not a simple answer. And I have many naysayers that say these organizations, they don't really do anything, but you can't win if you don't try. So got to get more involved. Maybe you'll feel like I'm not really getting anywhere. I'd go back to the old Jimmy Valvano phrase, never give up. You get down and out and frustrated and depressed, but you can't just give up and just buy a new car that you polish the fender on. You've got to somehow find a way to keep trying. So the other little mantra that I live by two guys who I think are great philosophers and economic advisors from the late 20th, early 21st century. And those would be Mick Jagger and Keith Richards.
Yeah.
But I'll give you a little aside. If you pay attention to the words in the Rolling Stone songs, many of them were written by Jagger. If you know anything about him, when he started singing for the Stones, he was in his master's program at the London School of Economics. And if you know anything about the British educational system, you know what it takes to get that far. So my point is that when you talk about realities, economics, living life, getting through life, they have a lot of good advice. So I come back to the verse in one song, and it goes, you can't always get what you want. But if you try, and by try, Jimmy Valvano, never give up. No matter how bad it seems, you keep trying, you keep hitting at it, keep trying to turn something over, to turn something around. The next line, sometimes you just might find you get what you need. And to me, that's one of the most important phrases that drives my life. Because all of us as physicians and others, in whatever we do, you have these dreams, these goals, these aspirations, and they may not work out. But if you keep trying, you might find that you get what you need, and that what you need might actually be better. So my point is down to the individual. And what I try to advise people I talk with is it's depressing. It makes you want to give up. I'll just buy a new car. I'll just go to the bar tonight or whatever. But again, keep struggling. You may find, oh, here's a pathway. Here's something I can do that I never realized. Here's a way I can make a difference that I hadn't thought about. But if we all don't give up and continue to try, hopefully we can get there. We can get what we need.
I love that. And I think that's a great way to end today's podcast. And I'd love to have you back and dig into this more. And I think what you're sharing there is what we've shared many times on this podcast, but it's worth repeating, is there's individual agency. What can I do personally? And then to solve these bigger problems takes collective agency. None of these problems are meant for us to carry on our own. And we're coming up on Leadership and Advocacy, one of my favorite conferences that happens at the American College of Emergency Physicians. And that's when we meet in DC, and then we end the conference by going up to the Hill and meeting with lawmakers and their aides. And I'm not going to be able to go this year. And I'm actually having a little bit of FOMO right now that I'll be missing this year. But this is long work. This is going to take many of us working together, just like any other massive change. This is on the same level to me as the civil rights movement, for us to be able to care for the health of our people. And that movement was done through community. And so I would encourage the listeners that if you're energized by this, you must be, if you're listening to the podcast, if you made it this far, do this in community, whether that's ACEP, AEM, SAM, your state medical society, wherever that is for you, do that in community. And the more of us that, get off the bench and pull ourselves out of well of sorrow, which I've been in, it feels a lot better to be in community with others and sharing the struggles, getting out of the shame that many of us feel that we can't do better by our patients, and to be collectively working for something. So that's really my call to action for the listener, is find one way that you can do some of this work in community. So with that, Dr. Severance, is there any parting wisdom, and how can our listeners connect with you? And we'll be sure to put some of your recent papers in the show notes.
There, again, I could go on and on and on, but like I said, never give up, keep trying. You'll keep finding new and maybe unexplored ways to make a difference. Take advantage of those when you come to it. I'm out there willing to help, willing to talk to individuals or groups. I'm available through multiple pathways. My largest social media platform is LinkedIn, which they can find me on. I have email addresses at Duke and Gmail, which is my name, harry.severance@duke.edu or gmail.com. So I am readily available to try to reach out and help and continue to push for healthcare change.
I love it. All right. Well, from one change maker to another, I thank you for what you've done and what you continue to do. And I'm excited for our continued change-making collaborations. Thank you, Dr. Severance.
Thank you so much for having me.
Thank you for listening to Heartline, Changemaking in Healthcare. If this episode sparks something for you, I'd love for you to share it with a friend or colleague who's walking their own changemaker path. If you're interested in coaching, consulting, or speaking engagements, you can find me at AndreaAustinMD.com or connect with me on LinkedIn and Instagram. I work with individuals and organizations who are ready to build meaningful, sustainable change without losing themselves in the process. The views expressed on this podcast are my own and do not reflect those of any organization I work for or with. This podcast is for education and entertainment purposes only and is not intended as professional advice, including but not limited to medical or psychological guidance. Until next time, keep following your heartline.